Hi everybody, I'm Kate Wakelin and I'm from Neuroendocrine Cancer Australia, and welcome to our weekly Facebook Friday broadcast where we focus on a topic each week that's relevant to people living with neuroendocrine cancers in Australia. So thanks everybody for joining us live. You will see that I have got a guest here with me, which is really exciting. So I'm going to introduce Megan a bit more in a minute, but before I go on, I would just like to acknowledge the traditional owners of the land that I am broadcasting to you from, which is the land of the Wurundjeri people of the Kulin Nation, and just would like to pay my respects to elders past, present and emerging. One of the things I love about where I live is that I am very close to the Yarra River, and I'm really fond of going running along the Yarra River, and in the Woiwurrung language that's called the Bitterung. So that's just something really special about where I live. But I'm also acknowledging that everybody watching today and Megan as well are beaming in from all corners of the world, well actually via YouTube further afield, but certainly in our Facebook group from many other places in Australia. So just extending that acknowledgement to where you are joining us from. So I'm just going to do a very brief COVID update, Megan, before we get to your stuff. And I'm so excited to hear from you and so grateful that you joined us today. But I feel like I'm competing with a Daniel Andrews press conference, which I know is happening live in Melbourne, I think as we speak, which is, so I think if you're in Victoria or particularly in Melbourne, we're sort of bracing ourselves. There's been some concerning cases. So as always, if this is impacting on you or your treatment or your ability to get your medication or anything like that, please do give me a ring, because as you know, there's often some things that we can do from in an advocacy space, getting things working better for you. And actually, Megan and I have been working together for the past year, essentially, on a committee that's been really focused on these sorts of things. So that feeds in really nicely to this conversation with you, Megan. So maybe we've talked about some questions for us to chat about, but as you know, there's a spot for you to put your comments in on the live feed. So I would really love it if you've got questions for Megan as we go. Please put them in there. Also, just feel free to tell me that you can see us, because it's a bit funny when we're on Zoom and on Facebook. Sometimes it's like, is anyone there? Anyway, we're recording it, so if it does drop out, it's okay. Megan, tell us about, sorry, I'm going to skip to, before I really talk about the topic we're talking about today, I just wanted to get a sense of your role and where you're from.
Thank you, Kate. So I'm Megan Varlow. I'm the Director of Cancer Control Policy at Cancer Council Australia. And most people know that Cancer Council is a federation. So there's one in every state and territory. And then I'm in the national organisation, so Australia, and our focus is very much on policy. So we work with the Federal Department of Health and the federal government and look to see improvement in policy as it pertains to cancer control. So from prevention, cancer screening through to cancer treatment and the issues that I'm sure that you talk about in this group quite often. And so one of the things that we've been working on for the last couple of years actually is the financial burden that cancer can have on some people. And so a piece of work that we've done is the standard for informed financial consent. So I have never tried to share a video to Zoom and then have it work in Facebook, but I'm going to try because it will give a little introduction to informed financial consent, and fingers crossed that this works. I'm just going to press the play button now.
When someone receiving medical care gets bills they weren't expecting, it's called bill shock. Bill shock can have a significant impact on a patient's physical, financial and mental health. For cancer patients, out-of-pocket costs for their care can accumulate, sometimes over months or years, and what they're able to afford can change throughout the process. Trying to cover these costs may drive decisions that can lead to financial hardship, distress, or avoiding the care they need. Neither public healthcare nor private health insurance cover every cost of care, but a patient will always have options. Informed financial consent allows patients to plan and prepare for treatment costs. It's an essential step in patient care. Informed financial consent means patients have a right to know their doctor's costs, who else will be involved in their treatment, where to find information about their costs, and whether there are alternatives that offer the same or similar benefits at less or no expense. Patients also have a right to know if costs change throughout their treatment. To provide the best care possible, doctors need to ensure their patients can participate in informed financial consent. This means clearly outlining costs to patients and making sure they understand and feel comfortable. Everyone deserves the chance to make the best decisions for their care. So if you have financial concerns relating to cancer treatment, talk to your doctor. You can also reach out to a social worker, financial counsellor or Cancer Council for support and to explore your options.
So fingers crossed that worked.
It looked like it worked pretty well from where I was sitting, Megan. So thank you. And I know when we were talking about what to talk about, you were saying that that would give us a really good little overview of what you've been working on. So thanks for sharing it. Can I just ask how the project came about? Like, how does the Cancer Council decide that this is an important enough thing to do, devote some resources to?
So most of our work actually when it comes to cancer care is either driven by what we hear from patients through services like 13, 11, 20 or collaborations like the one you talked about earlier where we've been working together on the COVID response. And it's about what is it, or is there something that in a policy sense we might be able to do that makes a difference? And unfortunately there isn't always something, but when there is, then that's one of the ways that we choose what to do. The other thing that's really important is the environment in which we're operating. So Minister Hunt has had a particular focus on out-of-pocket costs, and so that gives us a way in, means that there's more interest generally in the department and in politicians around those sorts of issues. And so when we get the two things together, feedback from patients that this is an issue and the opportunity that makes it feasible, that's why we choose. And we know that financial burden is a really big problem. So BCNA did a survey, Breast Cancer Network Australia did a survey of their clients about 3 or 4 years ago now, and found that the average out-of-pocket costs in the first year were about $5,000, and that's a lot of money, particularly when people have had to stop or change their work or their circumstances have changed as a result of their diagnosis. And so our partners on the standard were Breast Cancer Network Australia, Prostate Cancer Foundation and Canteen. And the reason that we four worked together was because the Prostate and Canteen had also done similar work with their patient groups that had shown quite high financial burden. And so our chief executives got together and got cross and said, so what is it that we can do about this? And the standard is one of the things. And really part of what we're trying to do is promote conversations. We want patients, we want clinicians, we want practice staff to be having conversations about cost and being upfront about it. We're in a system in Australia where out-of-pocket costs are part of the system. They're not avoidable. Everyone gets some sort of out of pockets. Even if you're completely treated in the public system, there'll still be something that you have to pay. Parking is a good example. And so we can't completely remove them. It's the fact of our system. And so what can we do? And one of the things is about increasing transparency. There's nothing worse than getting a bill 6 weeks later that you didn't expect to receive, that you weren't told about, that you didn't realize. And a good example, possibly not so relevant for neuroendocrine cancer, is for surgical assistance. So most surgeons don't tell their patients that they'll have an assistant and that the assistant will bill. They assume that everybody knows that, but everybody doesn't know that. And so it's about trying to have that conversation and for patients to feel like it's okay to ask their health professional, their doctor, so how much might this cost me, and are there different options for me that will either cost less or that might have no cost associated with it at all?
Oh, that's so interesting, Megan. And I'm going to ask you a question that I haven't told you I'm going to
That's
ask.
okay.
So, because I can see like where there are some resources online, and the video is one of them, but I'll make sure I share some links afterwards to where you can get more information. But so it's obvious that you've done some work in empowering patients to have those conversations with their health professionals. What sort of work are you doing in the health professional space to encourage clinicians to have these conversations with their patients? And is there any incentive or disincentive? Like, is there any way that we can hold our health professionals to these standards?
So I'll start with the first bit of the question because that's a bit easier. Essentially, we are doing quite a lot of work with health services and clinicians to raise the profile of informed financial consent, and also provide them with resources that let them implement it as part of their business as usual in their practice. And so we've got, just like we've got patient resources, we've also got health professional resources that essentially are working them through what are the steps to be able to ensure that their practice is supporting their patients to receive informed financial consent. So we have a pledge, for example, whereby the practice signs up to say that all of our patients receive informed financial consent. They can stick it on the wall. I only know of one practice who's actually done this, but it's possible. Pop it up there to be able to make it clear. There's also resources, things like often practices that have been in operation for a long time forget or don't realize that patients don't understand the system in the same way that they do. And so checklists and pro forma forms to be able to help them to say, this is the costs that you might expect. These are the types of people or types of professionals who will be involved in your care. This is the way that you can contact them. And the other important bit is clinicians often assume that private health insurance is easy to navigate, which it certainly is not. And so some resources for them too about making sure they provide patients with the right information so that you can then find out from your private health insurer what might or might not be covered. So we are doing that work as well. Something we have worked with COSA members, and COSA just a couple of weeks ago, so the Clinical Oncology Society, which is the multidisciplinary organisation for health for cancer professionals, they've just started a financial burden working group, and the idea is to raise the profile among COSA members and to get all COSA members to be ensuring informed financial consent. So that's one of the things that we've got going. And we've also got there's a practice in Melbourne actually where there's some doctors who work at both Peter Mac and in the private setting, and so they've agreed to be our first pilot implementation site. And so they will do a bit of they'll do the implementation and then provide lots of feedback to us on what worked, what didn't, what was helpful. And I think that's a question, I don't think I'm supposed to be asking questions of people watching the Facebook Live, but my question is, if you go and if you go and have a look at what is available in terms of information for patients, is it sufficient? Is it useful? Is there something else that we might be able to do that would make it easier for you to have these conversations about financial, or about cost, and about informed financial consent? And I completely acknowledge that it's a difficult conversation to have with a health professional. Our focus, most of our focus actually, is on getting health professionals to drive that conversation. In an ideal world, a patient shouldn't need to ask, so how much will this cost? Because the health professional should have already told you. But we don't live in that world. And so we need to, that's right, we need to be able to have that conversation initiated from both sides to make sure that it's had.
Do you know, I think this is something that comes up again and again and again in various ways for people with cancer, and especially neuroendocrine cancer, where there's some little individual things that make it even more, I think, important or challenging, is that I think often we think as a patient that the doctor or the clinician will tell us what we need to know, or, know enough to guide us in the right direction that we need to go. And something that I know I learn over and over again for in the neuroendocrine space is the importance of becoming your own advocate. And actually it can be really uncomfortable to be the person asking those sticky questions, like who likes talking about money or sex or death, or these subjects that we often in polite conversation don't raise, but actually these are really important. Like you said, these are really important conversations to have. I wonder if you could tell us, Megan, what should people do? Like if they feel like they have had, they haven't had enough information about the cost of something, what should a person do? What can a person do?
So our suggestion is to treat cost like you would any other aspect of treatment. So if you leave your appointment and are not quite sure when your next appointment might be or what your next step in treatment is, you'd follow up and you'd give them a call and say, actually, I'm not quite sure where it is that I'm going next. We'd encourage you to have the same conversation about cost. If you leave that appointment and don't know the cost of the treatment going forward, haven't been provided with that information, then go back and follow up. And as you say, it's a difficult thing to do. It's a difficult conversation, but it is part of the responsibility of the clinician to ensure that you have that information. And so in some cases, it might just have got lost in translation, or they accidentally skipped it and were meaning to tell you and didn't. Lots of practices have like a written information, this is what we expect, but don't always remember to give it to patients. With the 50 billion pieces of paper that you get, sometimes it can get left out. And then other times they might just not have told you, which is not okay, but it's information that you need to know. And so our first step would be to follow up with that practice. Contact the practice manager or the nurse or the doctor or whoever it is that you would normally contact, depending on the circumstance, and see if they can provide that information to you. Because the other thing to remember is that cost is part of your decision making. And so just as you would think, if your doctor give you an option, you can have to use an example, you could have your injections at this place or at this place. You'd weigh up what's the difference between it. Is it about the travel time? Is it about the ease of getting there? One of them is straightforward, one of them is a bit more complicated, but the complicated one might be cheaper. So you need that information to be able to feed into your thinking. And just like you would if they said, well, I can see you tomorrow at 2 o'clock or next week at 3 o'clock, you think about your life and whether or not which one's going to work for you best. Exactly the same considerations when it comes to cost. And so we know too that some people will make decisions on treatment based on their cost, and that's what life is like. You have to pay for things and need to be able to make those decisions, but you can't be expected to make that decision if you don't know. And so first step is to follow up with regard to cost with the practice doctor, clinician themselves. If you don't get any luck or you don't, that doesn't work, then it sort of depends how far you want to go. So you've got Kate as an excellent resource. There's if Kate has 12 people on the phone at the same time, this Cancer Council can offer something similar. Lots of hospitals have a service whereby the service itself can help you to find out that information. So particularly public hospitals, which do have costs that they don't always disclose, just like private centres, will have a number that you can contact to be able to find out that information. And if you get to the point where you want to make a complaint, then it is possible to complain with regard to cost or the lack of informed financial consent to your state-based healthcare complaints organisation.
Right, so you can take it all the way through.
Yeah. And there was a case recently in New South Wales where that happened. Someone, a doctor, recommended a course of treatment or a path of treatment. It was get treated in the private hospital, get treated in the public hospital, recommended the private option that was much more expensive for an elderly man who didn't have the money. His family ended up using their super to cover the costs, and then his daughter made a complaint and that was upheld in New South Wales. So
did that mean that the costs were waived for that person then? Sorry.
So part of the determination was I can't remember the word, but they got paid for those costs. So the hospital didn't. It was part of the order on the doctor. So the people got their money back, and they still got their the treatment, but that doesn't always happen. That was just the way that it worked in that circumstance. So there is that complaining option, and colleges are the other place that can take complaints, but that's much less transparent as well. So we do hope, though, it doesn't get to that, and that you just follow up and they say, oh, sorry, here you go, this is what you need to know.
But it's reassuring to know that even though it's at this point a voluntary standard, that there's still some like quite significant action that can be taken if things go awry. So that's really interesting.
Yeah, and the problem, I think, is that like you say, it's difficult to talk about costs. So often people won't ask the question, or they'll just go along with the plan, even if it's putting them into financial distress. So like, we acknowledge that cost is a fact of healthcare in Australia. It's something that is there, but it shouldn't mean that you can't afford to put food on the table or look after your family. We need to work out a way that they can both happen at the same time.
Megan, you mentioned before about public and private systems. A lot of people, when they are well and fit and healthy, they don't have the need to research the health systems and how they differ. I know I speak to people who, when they're just approaching diagnosis or just sort of starting out, they might make the assumption that, or my friends actually, you know, that they make an assumption that, well, because I've got private health insurance, everything's covered. But we know that's usually not the case. Is it maybe worthwhile for us to sort of talk about the sorts of things that are covered in the private system as opposed to in the public system? I know there's going to be individual variation there.
Yeah, so that's the best "it depends" question you could have possibly asked. So it depends on the way your state health system is organised, if they have public-private arrangements in place. So there are some places whereby it's a publicly funded service, but it's operated by a private provider, and that's like an extra level of complication. So there's a few of those around those sorts of services, and lots of, or increasingly more and more, radiotherapy is working in that sort of environment as well. Almost like the public system has outsourced that component to a private business. But essentially, in the public sector, you should, and should is an important word here, be able to access everything that you need to be able to receive the care that you need. But that won't always be without cost. And so sometimes they might not, a particular medicine or scan or procedure might not be covered by the Medicare benefits schedule because of the indications or where the evidence is at, those sorts of things. So that sometimes means that you'll have costs associated with it. Other times there are costs in addition that hospitals can pass on, like administration or other sorts of costs that can sometimes be separated out. And then sometimes a hospital might not have a particular service available in their own circumstance, and so they'll send you down the road to the place that offers that. And it's interestingly common how often clinicians don't know the costs associated with that. So they write the order form and say, here you go and have this scan. And if you ask them how much will that cost, they might not always be able to answer the question. And so, could you please find out for me, is a very helpful question to be able to ask them, because
it's a reasonable thing to ask your doctor.
Most definitely, because if you think, in two reasons why. The first is that it educates them so that they're aware what the cost of it will be for their next patient, but also it means that you're prepared. So if it's something that might be a significant out-of-pocket cost for you, you can then ask your doctor, well, is there another option for me to be able to get this scan or this treatment or this whatever without this sort of cost? And often there is, not always, but often. And the examples that we've seen are that you might need to travel further, or you might need to wait a week maybe, but you might be able to get it at a lower out-of-pocket cost. It might not be zero. That would be nice, but it's not always possible. But there are examples where they might have a deal with another hospital that's a couple of suburbs over, whereby that they can do that if you book into one of these appointments in next week or the week after. So it's always worth asking the question, is there another option for me in this regard? But if you don't ask about cost, then you might front up to that place down the road and discover that it'll cost you $500 and you might get a $27 rebate, which would be nice, but you've still got $400 and something out of pocket. And so knowing that before you get to the place, before you've booked the appointment, before you've traveled, that's really important. And so it's completely okay, and in fact encouraged to ask at the time when they're giving you that little order piece of paper, how much will this cost me?
Well, thank you for explaining that. And I think it's really reassuring to know that it's okay to ask your doctor directly, even if it's not a service that is, or something that the doctor's referring to in the hospital where you're being seen, but it might be out further in the community. Megan, I wondered if we could talk for a minute about COVID and the impact of the slam the borders, shut the borders situation that has been our reality in Australia for a long time now. And I know there's a lot of people in Victoria who are kind of holding their breath, and probably a lot of people in border communities who are holding their breath and going, oh gosh, what does this mean for my whatever it is coming up next week or 2 weeks? And we hope that we're past some of that, but you know. We did have some situations, and I know you and I have spoken about these situations throughout the year where, for example, someone might drive across a border to have a scan at a public hospital, and that scan is provided by the public hospital free of charge. But because of the restrictions and the requirements to do things like quarantine, if it's been across a border, it's been determined that the best place for that scan is actually just, down the road. But rather than being free, is going to cost several $100s. I know that there's been quite a lot of work done in the advocacy space for those sorts of situations. And how much success have you guys been having in terms of helping people where they're in that sort of stuck between a rock and a hard place?
So it's been firstly one of the biggest team efforts. So it's not just us. There's a whole heap of organisations who've been working on this, and not just in cancer either. So we've seen lots of our chronic disease colleague organisations, so thinking Stroke Foundation and Heart and other sorts of places where people need to travel for treatment. And we have seen improvements. So I'm not going to say that it's all good and rosy, because it probably isn't. But we have seen improvements, particularly in the way that border passes have operated for the people who have to cross the borders. So with documentation from the relevant clinician, border passes have been granted for people, and the requirement to quarantine has sometimes been altered. So they may, I'll use an example that I'm aware of. So someone, when the New South Wales Queensland border was closed, Northern New South Wales resident who had to travel to Queensland and come back, typically when they crossed the border into Queensland, they'd have to quarantine, but that's silly if you then just have to wait 2 weeks before you can go and have the thing that you were going to have that you were going to Queensland for. So part of the exemption that they were granted was to go into Queensland, it was for a scan, have the scan, and then travel back into New South Wales and quarantine after. And so the facility had in place things that would allow the staff who were working to be able to do that and for that to happen. Now, that's a good news story, but they're not all like that. And so I'd say that while we have seen some improvements, there are challenges, and my advice would be to always challenge it. So quite often the first response, particularly if you have to apply for a border pass, is to say no. But by contesting that and saying, well, are you sure? is there a way that I might be able to do this? That's when we've heard of many more people having success. And so going back and following up, again, it's not something that you'll feel like doing, and you'll probably be very crushed by the original thing, but it does make a big difference. And particularly in those sorts of circumstances, as I said, we've heard of people who've had much more success the second time
So it comes
around.
back to that self-advocacy
It does.
that
And
we, yeah.
in some cases, it's been the clinician who's done that. So the patient has applied, has been denied contact with the doctor's office, who have then done the follow-up for the patient. So it's a bit of both, but we haven't seen more success from either side. So it's not better if you get your doctor to follow up compared to you. It's more about the follow-up itself.
Right. Right. So I guess if you're having issues like crossing borders, then it really pays to be persistent.
Yeah.
And I guess what I've been saying all along is that if you're experiencing, whatever it is, difficulties with, access to the things that you need because of COVID and made more complicated by your cancer, then let me know and we'll work out what we can do. And I think you're right, Megan, that we haven't always been able to, score runs, but it's worth having other people on your team who are advocating on your behalf. So,
and again, I think something to remember is that it's not something the clinician might consider. So they're mostly thinking about the medical treatment that you need. They don't think about the logistics, that you might have to cross the border, or in fact that it might be better sometimes for you to travel a long way than to travel a short way, depending on your circumstances. And so we had a case of someone the middle of last year who actually preferred to be treated further away from home, because for them they could then stay with family and have that support that they needed. And the clinician was surprised, like, why wouldn't you want to be treated close to home? But because of their circumstances, that was a better option. And so it is about that communication as well, to be able to say, well, actually, the border gets in my way, or that cost is not going to be able to something that I can cover, or if I could do this, it'd be better for my circumstance. And to be able to have those conversations, then together, you and your clinician can really get a plan together that's going to work best for your circumstances.
That's really great advice, and yeah, thank you for that. Megan, we have a lot of situations where people where a scan at one hospital or at one provider might cost a completely different amount to what seems to be the same scan for a very similar, what seems at least on face value to be a really similar kind of clinical situation. And I guess the other scenario that we hear about a lot is blood tests. Often, there's usually an out-of-pocket cost, but sometimes there seems to be not an out-of-pocket cost. And then the injections, the monthly injections, again, there's a large amount of variation in whether people are charged at all for that medication to be dispensed. And, as opposed to some places that waive a dispensing fee. And it doesn't actually, like, I know one situation with a major public hospital where the public hospital pharmacy charge a significant dispensing fee, and the pharmacy that's actually in the foyer of that hospital, so that's a privately run business, but they don't charge the dispensing fee. So is there any rhyme or reason to this stuff, and why does it exist?
So no is the short answer. And part of it is because of the way that our health system is operated. So with the differences between public and private providers, you will also see differences between states and the different agreements that they have between the state and federal departments of health, and then the different operators of hospitals in different geographic areas in states. So like you could drive past 3 hospitals or 3 centres and have 3 completely different scenarios for how they're set up and managed and charged and all of those sorts of things. So the reason they're different is because our system is a mixed system where we have different providers, different ways of charging and different ways of rebates being made. There's also the added complication of often it's comes down to something very specific, and so medications that are funded by the PBS, for example, will be funded for one particular indication that might, for all intents and purposes, in real life look exactly like something else, but because of the diagnosis or the particular stage of disease, they're not equally eligible under the PBS. And so that's pretty common, actually. You get the same sort of circumstance for scans as well, depending on a particular disease or stage of disease or situation, it might or might not be covered. And so they're the differences that mean that you get different costs, and there's not a lot that we as regular people can do about that. And it's why informed financial consent is something that we are really keen to have as part of the everyday conversation that people have. And so you're able to have that conversation, and clinicians know that if I refer this person to this place, this is what the circumstance is going to be. And so that public hospital that you talk about, hospital pharmacy charges a fee, but community pharmacy in the foyer doesn't. With that knowledge, a clinician can help their patient to make a decision that is best for them. And so our experience is that the clinician doesn't always know that, but the patient does. And so making sure that your doctor knows, well, do you know that if I take this script downstairs and turn left, it'll cost me this much money, but if I turn right, it'll be free. They can then help with those sorts of discussions. And so that's something that we know lots of clinicians are aware of, but lots of clinicians also are not aware of. And so it's only through their colleagues saying, oh, did you realise that our hospital charges X? Or their patient saying, well, is there another option? Because last time I went there, I had this out-of-pocket cost and I'd prefer not to have something of that magnitude again, thank you. And so it's sort of a two-way education to make sure that everyone knows.
Is it worth asking the provider? So, you know, if you've been told to have a scan at a particular clinic, or you've been told to have a blood test at a particular place, is there any point in asking the clinic or the person who's sticking the needle in your arm, is there any way I can wriggle out of these fees? Maybe before the point of the needle going in your arm, it's probably not the time you want to be having an awkward conversation. But yeah, is there any point, like, do you know if that ever makes a difference?
So asking might not always make a difference to the result, but it's always worth doing. And so another example, one of the clinicians who worked with us on the standard, she works in a large public hospital in Melbourne, but her hospital doesn't have the some of the services that are available in other hospitals, so she refers to a private provider, and she has negotiated by which if she refers this set of patients, they agree to bulk bill, and that's something that she's been able to negotiate with the provider.
So the clinician's done that.
Yeah, and she's unusual, I grant you that, but it goes to show, I think, that there's always room for having the conversation and asking the question. Just like a GP can decide to bulk bill someone or not, a specialist can do the same. For services, there's sometimes that option. There's also often services, particularly if we're thinking about blood tests and scans, often they have like a discounted price or a price they don't advertise, but that if you ask, they're willing to give you. And so asking is always worth it. It's almost like the adult child cost when you go to the movies. Sometimes it's worth saying, is there a way I can pay less here?
I feel like I'm buying a fridge, Megan, like, you know, tell us your best price. What about if I pay cash? But it's sort of strikingly similar in some ways, it seems.
Well, and part of it is the way that our health system is set up, and that we have people who they're operating a business, and so they need to set their fees to be able to cover their costs, and sometimes they choose to earn less of a fee to be able to provide a service, and so it's worth asking.
Good to note. Megan, we've been talking about clinicians, and I'm aware that we've been mostly talking about doctors, But doctors aren't the only clinicians in the mix, and I wondered whether this sort of standard or this sort of applies to like allied health and other health professionals as well.
So the standard explicitly includes all health professionals. We tend to default to doctor or clinician as a shorthand, I suppose, but it really is designed to be inclusive of everyone. And in fact, the referrals between medical specialists, doctors, and allied health professionals is often one of the times when you don't get cost information, because in some hospitals you have allied health services available in the hospital, and in a public hospital that's with low or no charge, and in a private hospital it's quite clear and obvious what the cost is. But if you get a clinician referring you to a dietitian or a physio or someone who is operating in private practice, the understanding of fees from the person doing the referring between the person they're referring to can sometimes not exist at all. And so yes, the standard applies to all health professionals, doctors, allied health providers, the whole spectrum, and we'd encourage people to ask the same questions of their dietitian or their physio or their speech pathologist, their psychologist, as they would their medical specialist. And it's just like with medical specialists, it's variable with allied health professionals as well. Some of them will be like some clinicians, like some doctors, onto it, provide you with a list of fees, tell you everything up front. Others won't, and so you'll need to ask. And it's the same situation. You don't want to sign up to a course of treatment or agree to something where you don't know what it's going to cost you over time.
So I had we had a question this week from someone who had been referred to an allied health professional at a private clinic. The private clinic had contacted the person ahead of time to talk about costs, which is probably quite good. That was an upfront conversation, but then the clinic wanted to get the person to pay for that service before the appointment, and actually wanted them to pay over the phone. I'm not asking you to, provide a pronouncement about you, but I wonder, does that happen very much? And what would be your suggestion for managing? That seems unusual to me. And is it okay? And what should they do? And
yeah, so it isn't something that we've heard a lot about. We are very pleased to know that there are lots more practices out there who get in touch with the patient before the appointment and make sure that they understand fees and all of those sorts of things. But the prepayment before the appointment is, to my understanding, quite unusual. So most places you may need to pay before the appointment, but it will be on your way in when you're at the place, rather than on your way out. But yes, that's unusual. I haven't heard something like that. And my suggestion would be to understand why they would like to do that. If it's about no-shows or their concerns, I actually don't understand why you'd want to do it, but to understand why they'd want to do it and to have that conversation. Because just like something like a blood test or a scan, there might be other options available for you. Exactly the same thing with an allied health provider, is that if that's what they're asking to be able to provide the care to you, and if you're not comfortable with that, then it's always a good idea to go back to the referring person and saying, actually, can you send me to someone else, please?
Okay, well, that's really helpful, and thank you. The conversation in Facebook group has been really quiet. I think everyone's just been listening very intently to what you've had to say, which has been fantastic. Can I just say, Megan, and I always love the way you speak so clearly. When I grow up, I want to be just like you. But I guess it's a chance for anyone, in terms of last minute questions, if there's things that you would like us to chat about, or like me to ask Megan because she can't see the questions, then this is your chance to go ahead.
Yeah. And can I also go back to that shout out for, once you go away and think about this, if there's anything that we could do that will make it easier for you to have that conversation about around financial consent, please, however you communicate with Kate usually, send it through to her, because it's really valuable to understand what's going to make a difference so that we can provide those sorts of prompts or resources or whatever it is that will make it easier for you to have that discussion.
Yeah, and I'm really happy, like if people just want to comment on the video or get in contact with me through the usual channels, which is always in the notes from the videos. So, and I'd be only too happy to pass that feedback on to you, Megan.
Oh, thank you.
Also just wanted to briefly mention that we are doing quite a lot of work, the Neuroendocrine Cancer Australia side of things, with our consumer advisory group and with our board and our professional networks around improving this situation for people affected by neuroendocrine cancers. We feel that probably some of the disparities, or the reason behind some of the disparities, is that it might be a structural issue with maybe there not being the funding structures set up for some of the things that are considered in practice to be mainstays of treatment for neuroendocrine cancers. So we're actually working quite actively at the moment to see if we can bring about what's called an optimal cancer care pathway for neuroendocrine cancers, and with the intent that gathering together the evidence around some of these scans and tests and treatments might then help us to advocate for more, a flatter playing field for people affected by NETs in Australia, because there's just such variation and we hear about that so much of the time. So it's a watch this space. Our health ministers and the departments and our health professionals have all been rather distracted over the last 12 months with something you might have noticed called COVID, but we continue to work really actively in this space. So we'll continue to do that as time goes on. Megan, was there anything else that you felt like we should have covered, or that we were going to cover, or that you have thought that you'd like to mention before we finish up the conversation today?
Nothing really in addition, Kate, but just to emphasize that it is difficult, I completely agree, but it's worth having the conversation. And so whatever it is that will support you to do that, be it preparing in advance and knowing the questions that you want to ask, to take along someone else who can be the one who asks the question. So no one will be surprised to know that in my family, that's my job. And so I go to doctor's appointments with people to ask all the questions that no one else wants to ask. Like, if you've got one of those people, drag them along and make that their responsibility. We're not leaving until we know these things, like all the usual things that I know you know about, but to think about it when it comes to cost as well, that you wouldn't think about leaving an appointment not knowing what the next steps in the treatment plan were. Exactly the same for costs. Don't leave until you know what the cost implications of that treatment plan are as well.
Well, that's really fantastic advice, Megan, and I think it's probably a good place to finish on. There was a comment in the Facebook group that I did want to just read out to you, which was that it was very interesting to know, especially about the assistant with some procedures and other hidden costs. So a grateful group member who's been watching along. So I just thought I'd pass that feedback on to you. But if there are further comments, and particularly around feedback around the resources that Cancer Council has produced, we love the Cancer Council resources, and I know everyone gets sick of me plugging them every week, but they really are fantastic. But they're only shaped by consumer feedback, by people affected. So just like our resources, if there are things that you're watching and reading and thinking, oh, well, gee, it'd be good if they said this in a different way or explained this a little bit more clearly, then, the only way we change it is to get that feedback. So thank you in advance for giving us those comments. We're just about to finish. So Megan, I've got a couple of little bits of news that I was going to talk with our group about. You're welcome to stay with us for that, or if you want to turn off your Zoom and have a minute to just before the next thing, then that's absolutely fine. But we're so grateful to you for your time today and explaining this all so clearly to us, and so thank you.
Thank you. It's been a great opportunity, and it's really good to talk about something that's important with a different group of people. So thank you, and I will leave you. So see ya.
Fantastic. Thank you, Megan. So I'm not going to keep you too much longer, but I did want to talk to our community just about a couple of studies that are happening. I know we tend to, studies and surveys seem to come in waves, and we have, you know, sometimes it feels like, you know, we get 5 invitations in 1 week to do surveys or interviews or take part in research. So I did post about one the other day that you might have seen in the Facebook group, but there were 2 others that I did want to make sure I mentioned. The first one is called Direct Nets. Direct Nets is an international study, and it's a really interesting study. It's an online survey-based study, and it's really wanting to drill down about why people might just choose a particular treatment over another particular treatment. So the way it works is that it asks you to make choices between 2 sort of different treatment scenarios. And then they ask you, it's weird because there's a health professional version as well, which I have done. So I know what they're asking. Then they ask a very, like, so they ask sometimes what feels like the same question in just slightly different words. So it can feel a little bit repetitive. And I know a couple of people were looking at it going, oh, this sort of, does this even apply to me? Does this make sense? So I would encourage you to have a go. We've only had, I think, just over 50 people in Australia take part in the study. I went to an update yesterday where there were some other countries that had done more, and not that we are competitive at all, but we do like to really represent when it comes to Australia. So I know that we have very many more than 54 people in Australia affected by NET. So I would just urge you, I'll share the link. It's still open. It's not open for very much longer, but it's going to give us some really useful feedback. And I guess these international studies that we have an opportunity to participate in are fantastic, because it means that we're not just looking at data from a relatively small group in Australia, but we're actually able to combine those data sets with other countries. We can make comparisons and sort of draw some conclusions about things like cultural differences between countries, but also really help health professionals and in terms of framing, describing the treatments and the side effects and helping people through that decision-making process. So I would really encourage you to do that. That's enough of a plug of that one. The other one is just for our Victorian viewers. So apologies if you're from another state, then just talk amongst yourselves for a minute. But there is we did have a survey late last year about telehealth. And this is really in the aftermath of COVID, that, or in the during of COVID, because I wish it was an aftermath, but we're still in it, where lots of appointments were transferred to telehealth. And look, we've had lots of conversations in our Facebook private discussion group about the various pros and cons and preferences and experiences around telehealth. So there was a survey late last year that we did encourage people to participate, but this is another one. It's a separate study, and we're really keen to provide people the opportunity to provide feedback about this, because we know it's really important, and actually telehealth is here to stay. So providing this sort of feedback now gives you a chance to really impact on the recommendations for health professionals and hospitals about the best ways of doing this. So, you know, I've certainly heard some stories about things like doctors calling patients in cars, and look, most of the experiences have been really fantastic, but sometimes it's been, you know, poor quality phone or internet services. Sometimes it's that there's been no camera or no screen, so you haven't been able to see pictures that you would like to see. There's been some things about, you know, the doctor not being able to access all of the clinical information. So I know that there are stories out there, and I'm really keen to make sure that you've got your voice heard in this area. So again, this study is just for people in Victoria. We know the issues are far broader, but for people in Victoria, if you have experienced telehealth, and specifically if you were diagnosed in the past 4 years. So that's not everybody in our Victorian community, because we know, I actually was talking to a lady yesterday who was diagnosed in 1999. So you wouldn't be able to take part. If you were diagnosed in the past 4 years, if you have had a telehealth appointment for your cancer care any time after March last year, 2020, so since the COVID pandemic restrictions were introduced. But importantly, if you've been a carer of someone with cancer in Victoria and have attended a telehealth appointment with them for their cancer care anytime after that time, so March 2020. So this is an interview-based research, so it's not another online survey where you have to try and find the box to click. They're actually going to be talking with you either over the phone or via Zoom to really talk about, really drill down into, well, what was working for you, what was comfortable for you, what worked, what didn't work, what could be improved. So we're really keen, once again, for people with neuroendocrine tumours and who are affected as a carer of someone with neuroendocrine tumours to really have your voice heard about your experiences, and, you know, so we can all improve things moving forward. So look, I'm going to leave it there. I really appreciate everyone hanging in there. It's been a bit of a dry topic today, but I think you'll probably agree with me that Megan is a really fantastic and clear communicator, and I certainly learnt lots from her joining us today. So thank you for watching with us on our Facebook private discussion group, and for those of you who are joining us later on via YouTube, then I'll make sure that I do put the details of our Facebook group in the notes on the YouTube station, on the YouTube channel, YouTube video. I'll get there eventually, because sometimes even if you've been living with NETs for a long time, there are things that you might not be aware of that are there for you. So the Facebook group is just for people affected in Australia, but also there are other similar kinds of support services in lots of other countries. So maybe on this one I'll put a link to INCA, which is the International Neuroendocrine Cancer Alliance, which has representation from lots of countries internationally, and links to lots of different support groups internationally as well. So thank you once again. I'm going to stop yabbering on. I'm going to finish the video, and thanks everyone for joining me. I'm looking forward to seeing some more comments as you watch later on perhaps. Take care everybody, and I'll talk to you soon.